Right. Morning, guys. So we are here today. It is May 11th. I'm on my way to the hospital. I'm going to be on the adult inpatient palliative care team. For those of you guys that are new, my name is Dr. Tochi. I am a hospice and palliative care fellow at the moment. It is a great day. I was currently on the inpatient pediatric team, so it's a little bit of a shift for me, and I'm looking forward to get back to my adults so I can help manage them. So we're gonna go ahead and get to the hospital. We have about, I don't need the AC right now. It's gonna take about 21 minutes to get to work. I have a lot of objectives for today. I really want to take this time because I have about, I think 12 weeks left of my fellowship. So there's a couple of things that I want to make sure that I'm able to get down in terms of learning so I can be prepared for my attending job that's going to be starting in September. But just a little bit of reflection for the last 2 weeks. For the fellowship program, we actually need to be on the pediatric team, and the pediatric team was quite different, mostly because they're kids and I haven't actually managed kids since I was in med school, which was like 2020, 2019 time when I was doing my pediatric rotation, and I haven't seen kids ever since. And honestly, even that time that I was doing the inpatient or just the pediatric rotation, I didn't really have any inpatient time because of COVID. So I lost a lot of that experience that I was supposed to have during my med school experience for managing kids. But regardless, it was a good experience. Very sad, very, very sad. Kids that were passing away, kids that were going through very serious illness. It was quite the experience, but I think it was definitely needed because I needed to get that experience, take away some of the things that they actually do in the palliative care team for their goals of care conversations, because it was quite different from what we usually do for the adult side of things. But anyways, regardless of all that, I had a great time on the pediatric team. I'm going to be back on my adult team. The adult team is made up of a bunch more people. On the pediatric team, it's only it's the one attending, which is usually a pediatric ICU doctor, or it's not always a pediatric ICU doctor, it's just how our staff is. There's one attending, there's one nurse practitioner, and then there's also one chaplain, which was a very small team. So even though the adult team has like the same amount of patients that we see every week, it's such a much more smaller team. So a lot more busy, on our feet all the time. But for the adult team, we have 2 attendings on at a time. We have 2 nurse practitioners, we have 2 social workers, and then we have a chaplain as well. And then usually the way that we have the setup of the week, usually the weeks go from Monday to Friday, and then there's an attending on Saturday that covers only as needed or really important consults. And during the week on Tuesday and on Thursday, we have something known as IDT, which is interdisciplinary team meetings, where we have the inpatient hospice team, we have the inpatient adult team, and we go through the entire list, give updates, and if there's anything concerning or anybody that may go onto comfort care and transition into the inpatient hospice team, then we usually give the hospice team a heads up there. That way they can be on top of everything. But that was the kind of the setup. And then all the other days we have a nurse practitioner that holds our pager, and they kind of field the consults, which is really nice because from my residency program, it wasn't really like that. Usually the attendings just hold the pager and they're the ones accepting the consults. But at my fellowship program, the hospital is way, way bigger. So we have to make sure that we're getting appropriate consultations because there's so many people that can get palliative care, but a lot of people don't really have a good understanding fully of what palliative care is and what they can and cannot do. So sometimes we get consultations during the week that are not really appropriate for our team, or sometimes they just need a little bit of redirecting, a little bit of teaching, or just a little bit of a kind of like rearrangement of what their consultation should be. So that is something that we do with the nurse practitioners. They field the consults, and then once the consults get fielded, if we do figure out that it is an appropriate consultation, then they get distributed amongst the team. So either it goes to one of the 2 nurse practitioners, one of the 2 attendings, the fellow, which would be me. And then if we have other learners such as 4th year residents, or not fourth year residents. If we have like second, first, or third year residents, then we would give them the patients as well. So usually that's how like the setup of the team actually is. It's a pretty cool setup. It's a really nice team. I've had a lot of fun with them. I think this is the 4th month that I've been with the team so far, and they're gonna be real fun to work with because we've kind of developed a rapport so far, and we all kind of know each other's working styles. So really looking forward to that. And usually the days are from like 8 a.m. to like 4:30 p.m. Usually we don't accept late consults because we have to have time to like build rapport with the families, do like a full thorough analysis. And palliative care has really strict kind of like work-life balance, and we want to make sure that we give, you know, it's just due, because a lot of things don't really happen after 4 or 5 p.m. in the hospital in terms of like distributing resources, figuring out what they need. And we usually like getting the consults in the morning to like early afternoon. That way we can have time to set things up and get things rolling, as opposed to like 4 or 5 p.m. when people are getting ready to do shift change, getting ready to leave, which is not really an appropriate time to do a consultation. So that's how it is. That's how we like it. And I don't know, if you guys are out there and you're residents or attendings or whatever, the courteous thing in terms of like consult etiquette is to not do late consultations, or if you are going to do it, then at least give us a heads up if it's okay, if it's a next day consultation, so we can actually do an appropriate consult. So I am about 17 minutes away from work. Usually Mondays, it's not really this bad in terms of getting to work. Sometimes there's like an accident. There's always this one ramp here that is always like a huge issue in terms of like getting onto it and then getting off and then being able to like zoom over to the hospital. But yeah, usually because of that, I've been kind of like trying to like jerry figure when I should leave my home. I usually leave my home around 7:30 so I can get to the hospital by like 8:15, and then have time to go to the cafeteria, get some breakfast, and then get some coffee. That way I'm like filled and ready to be able to tackle the day. But in terms of some objectives for myself, I usually try to give myself an objective whenever I join a new team. I really want to get more and more experience with symptom management. Some of the main things that we manage on the palliative care team in terms of symptoms are pain, nausea, vomiting, agitation, delirium, constipation. What are some other things? Seizures, so on and so forth. And the reason why I want to get as much experience with that symptom management is because I feel like I had a lot of good training in terms of having family meetings and goals of care conversations in my residency program. And I feel like maybe as opposed to like some of the other fellows, I'm a little bit more experienced with that. Not to say that I'm perfect, but I do feel a little bit more comfortable leading family meetings, having goals of care conversations, and doing that aspect of things. So I really want to make sure that I fill in the gaps of things that I don't really feel that comfortable with. And because I switch teams every so often and switch hospitals, which we have 4 hospitals that we rotate to, sometimes I'll go to a hospital and it won't have as much experience in the symptom management portion. And I would say that the hospital that has the least management or experience with symptom management would probably be the VA, mostly because the primary teams are the ones handling the symptoms. And sometimes they'll reach out to us, but it's a much smaller hospital and the resources aren't as big or available as my normal hospital. So I usually like to rotate through these other hospitals as opposed to the VA when I'm trying to get more of that symptom management. And some of the things that I think that I'm trying to get more experience using is probably fentanyl patches, buprenorphine patches, as well as I feel pretty comfortable with methadone now. I think the other one that I want to get a good experience with is probably like end of life sedation or end of life seizure management or end of life delirium agitation management, because I feel like there's so many little small nuances that we've been learning in our lectures, and I want to actually put it into practice with some of our patients. So that is one of the things I want to try to get experience on. I'm going to let my consulter or like the nurse practitioner know that, so that way they can send me the consultations that have more symptom management needs. And yeah, we'll go from there. So let's go ahead and get into the day. I'm excited. All right. Finally here, made it by 8:01. Gotta call the shuttle, get some breakfast in. We have a list of 16 patients right now, which is on the lower end of seeing our patients. Usually it's in the 20s to 30s, right, Val? Yes. Yeah, usually 20 to 30s. I had one patient that we saw that is a Huntington's patient that is conserved. And this one's a little bit different for me because it's more of a bioethical case, which I haven't had too many of those during fellowship. And a huge thing that you have to think about when you are managing people that are conserved or don't have capacity is how to make medical decisions. And one of the things you have to identify is one, a kind of point person. We like to call them surrogate medical decision makers, or if they're legal, we call them healthcare decision or durable power of attorney for healthcare decisions. And usually we have to talk to them because the patient doesn't have the capacity to be able to reason through and make sound medical decisions. So this one, they are conserved, and they also don't have a family contact that we're able to get in contact with. So this is a little bit hard because making medical decisions for someone that we don't know and we don't have a family contact for is pretty tricky. So the ethics team is involved, and we're trying to actively find someone for them. That way they can kind of help make these decisions. And then besides that, we have a kind of an undergrad medical student or undergrad students that is following us today. And we went to go see another patient that is having a lot of nausea and vomiting. And this patient has metastatic lung cancer that has spread to the brain. And whenever we have someone that has nausea, we think about managing them from 4 different standpoints, and it's the 4 pathways for nausea and vomiting management. So the first pathway is through the chemoreceptor trigger zone. The second pathway is the cortex zone. The third pathway is the peripheral route, and then the fourth pathway is the vestibular route. So if this person has space-occupying lesions or metastatic cancer that spreads to the brain. So this will be more so management from the cortex route. And usually what you can do is manage them from 4 different pathways. So there's the serotonin pathway, the dopamine pathway, and then the neurokinin pathway, and then also steroids. So for this person, we don't really manage them with the neurokinin pathway because that's more so chemo associated nausea and vomiting, and this person isn't on chemotherapy, so I wouldn't use any medications such as a Prepotent to manage their nausea. And for this person, what I would usually do is rely on the dopamine pathway, so using like Haldol, haloperidol, or Compazine, which affects the dopamine pathway and antagonizes them. Or I would rely on the serotonin pathway, so using like Zofran as a medication, for example. And then the other medication I can use is steroids. And the steroids is something that we would do for metastatic lesions to the brain because we would want to decrease the swelling that's going on there, which can cause a lot of nausea. And then if we're thinking about a non-pharmacologic or non-medication route, one of the things that you can also do is radiation to the brain. And that is usually dependent upon how many brain lesions there are. If there's a bunch of brain lesions kind of spread out throughout the brain, you have to do whole brain radiation, and that's just pretty much spamming the whole brain with radiation to try to hit every single lesion. And if there's maybe like 1 or 2 of them, you can do more so like stereotactic radiation, which is more focal and trying to hit them as opposed to hitting the whole brain. And we usually like to rely on that method if there's a fewer amount of lesions, because doing whole brain radiation can lead to a lot of side effects months and years after the fact, such as cognitive decline or cognitive impairment, because you're hitting the whole brain and affecting the brain's ability to function. So those are the 2 cases that we saw this morning. We have about an hour until lunch. I'm going to go ahead and read through some of these other cases, and we'll see if any new cases come in. We're going to end the day there. It was a pretty good first day back on this inpatient adult palliative care team. I saw about 2 to 3 patients today. I saw that first patient that was more of an ethics case for that patient that was conserved that we talked about earlier. But the second case was actually a symptom management that we actually talked about as well, the nausea vomiting one. But then the last case was actually a hospice eligibility case. And usually what we say for hospice, and if you guys haven't seen a hospice video or what hospice is, I actually have an explanation video, so you can check it up in the description box or in the top right hand corner of this video. But for hospice, the main reason why people go into hospice is because they have some sort of terminal illness, and we think that they have about 6 months or less to live. So what we do on palliative care is that we're kind of the gate guards of those determining if they're eligible to be falling into hospice or not. So we have to see them, evaluate them, and then each diagnosis has their own specific criteria of whether or not they can go into hospice or not. So usually the most common diagnoses that we see are cancer, usually metastatic cancer. We also have heart failure. We also have COPD. We see a lot of Alzheimer's patients as well. There's some other criteria for like HIV and other conditions like that, but we usually don't see HIV anymore just because we have such good control with medications these days. But for the patient that I saw today, it was a patient with Lewy bodies dementia, which is a little bit of a kind of a trickier case to do for hospice, because usually there is a scale known as the FAST scale, which is a kind of a prognostication tool and kind of a staging tool for those with dementia. However, it's more specifically made for Alzheimer's dementia, which is a more predictable decline. And usually you have them losing all their functions pretty not rapidly, but pretty slowly for decades. But for Lewy bodies dementia is more of a combination of more psychiatric things, so like hallucinations, delusions, things like that, as well as the dementia component, as opposed to Alzheimer's is mostly just dementia components. And with the Lewy bodies dementia, it's not a predictable decline, and sometimes you think that they're eligible for hospice, but you actually evaluate them and they're actually doing a lot better. So one of the main things that we look out for are they having complications because of the dementia, such as aspiration events, which can lead to pneumonias, pyelonephritis, stage 3 to 4 sacral ulcers, which are ulcers that show up in the back region. And are you losing more than 10% of your body weight in the last 6 months, and other things of that nature. So for this patient, they're having slow decline. It's not quite ready for hospice. So we actually denied this patient to be able to be eligible for hospice. And what we said is that they can instead follow on home-based palliative care. So it's kind of like a home visit program where we have a palliative care doctor that has a bunch of resources that goes to the home and is evaluating them. And if they're continuing to have that decline, then that home-based palliative care doctor can actually make that switch to hospice at that time. So this was kind of a middle ground for us and that patient. The only thing that's a little bit tricky is because this patient is also having recurrent symptomatic hypoglycemia, meaning that their glucose levels are really, really critically low. And what makes that an issue is because hypoglycemia is life-threatening. So we're trying to figure out if we can try to optimize this patient's nutritional status with the nutrition consult. So they're going to see if we can try to get this patient some really high carb, high densely packed meals. That way they're not having these recurrent hypoglycemia, because if that's fixed, this person is probably not going to be someone that has 6 months or less to live. But if it isn't fixed, recurrent hypoglycemia is life-threatening, so it could be less than 6 months. So that is a big thing that we're going to be looking on for. As for now, we signed off on this consult, and I had the team reach out to the nutrition team, and they're going to see if they can try to optimize this patient. But besides all that, it was a pretty good first day. We had an undergrad student with us, so we actually were able to have some moments where I could do a bunch of teaching. I have this article that I'm going to read that my attending gave to me on pre-albumin versus albumin for what was it specifically for hospice, as well as nutritional markers. So I'm going to read that tonight and then jump into another day tomorrow. Tuesdays and Fridays, like I mentioned in the beginning of this video, is an IDT day, so interdisciplinary team meeting, where we have our inpatient hospice team, we have our social workers, our nurse practitioners, everybody across the board, our chaplains. We start off with a reflection, and then we go through the entire list and see, do we need to sign off on anybody? Is there any more support that we need? Is there a confusing case that we can all talk about? Usually there's about 14 to 15 to 16 people there. So I'm looking forward to it. I haven't been to one in quite some time, but I'm going to end the video there. If you guys enjoyed this vlog, I'm trying to do a little bit more vlogs like this. So comment down below your favorite part of the vlog. Drop a like if you haven't already, and I'll see you guys in the next one. Peace. Have a nice day.